So continuing the previous year NEET questions, 2025. So we will discuss this question from the last line. What is the next best step in management? So I think we'll be given a case and we have to come to the diagnosis and think of the next step. It's not the best step, it's the next best step. So please understand the question. So a patient with known history of bronchial asthma is currently on salbutamol and ipratropium pressurized meter dose inhaler. He now has nocturnal worsening of symptoms and frequent nighttime awakening. So straight away they are given it's a case of bronchial asthma. It is uncontrolled. With the current medication regimen, what is the next best step in management? So you know that salbutamol is a SABA. That is, it is a short-acting beta agonist. So a short-acting beta agonist causes bronchodilation. And ipratropium is a SAMA. That is, it is a short-acting muscarinic antagonist. So this also causes bronchodilation. Just a recap of basic physiology. Beta agonist is a sympathetic nervous system receptor. So when we are activating the sympathetic system, there will be bronchodilation. Muscarinic is a part of the parasympathetic system. And when we are opposing the parasympathetic system, there will be bronchodilation. Ipratropium and salbutamol both are short-acting agonists. So a patient with bronchial asthma is on 2 short-acting meter dose inhaler, but still he has worsening symptoms. Remember, in asthma, nighttime symptom is significant. Even if there is one night symptom, it means asthma is persistent or asthma is significant, right? So what is the next best step in management? So in asthma or COPD, there is something called step therapy. That is, when you are giving a particular regimen for the patient, if it is not working, we are supposed to add another drug. Even if that is not working, we are supposed to add the next step. So this question basically asks what is the next step in management. So we will discuss the options. Increase the dose of salbutamol. We should understand 2 terms when treating asthma. The terms are reliever and controller. Reliever is a drug which only relieves symptoms, or it's only short-term relief. It doesn't change the pathology. Controller is a drug which controls the disease activity. So it changes the disease activity. Like in rheumatoid arthritis, giving paracetamol or a NSAID is only going to relieve the symptom, but it does not change the inflammatory pathology. Whereas giving drugs like DMARDs, disease-modifying anti-rheumatoid drugs, is going to change the pathology. Likewise, in asthma, reliever only reduces the symptoms, whereas controller changes the pathology. So among relievers, we have 4. SABA, SAMA, LABA, and LAMA. SABA is short-acting beta agonist, example salbutamol. SAMA is a short-acting muscarinic antagonist, that is ipratropium. LABA is a long-acting beta agonist. So we have more among this. Remember one name, formoterol or salmeterol. LAMA is long-acting muscarinic antagonist. Example is tiotropium, humeclidium, glycopyrronium. So even though the names are so complicated, they just cause bronchodilation, either in the short run or in the long term. So it just causes bronchodilation and reduces the symptoms. What is more important is only the controller. So the example for controller is ICS, which is inhaled corticosteroid. So ICS is the controller and SABA, SAMA, LABA and LAMA are the relievers. In bronchial asthma, this is the ICS is the pathology changing drug. So the current trend is there is no actual standalone benefit for reliever drugs. Even mildest case of asthma should have inhaled corticosteroids. So this patient was actually receiving a wrong treatment. He was getting only the reliever drugs, but controller drug was not even added. So he has no relief with SABA and SAMA. So we will discuss the options now. So increase the dose of salbutamol. I think it won't be that much beneficial because salbutamol is again a short-acting beta agonist. It's only a reliever drug. It may not help that much. Start LABA and inhale corticosteroids. Seems a reasonable option because inhaled corticosteroid is a controller and LABA is a better reliever because it has longer duration of action, so it may be better than SABA. Theophylline, Montelukast, both are oral drugs. They come in the step therapy, but they come later in the step therapy. So like it comes like the last step when these do not act. So from the option, I think B is reasonable and B is the answer. This is a flow chart from GINA 2026 guidelines. GINA is an association which in every year publishes guidelines on bronchial asthma. GOLD is an association which publishes guidelines on COPD every year. So based on this guideline, see this is the step therapy. Even the mildest case of asthma, the first step will have inhaled corticosteroid and a long-acting beta agonist. We discussed formoterol is a long-acting beta agonist. That is the first step. When that does not work, we go to the next step. So we increase the dose. Like initial step will be as needed inhaler. Next will be a daily maintenance inhaler. The next step will be increasing the dose from low dose to medium dose. And see the last steps will be adding other drugs like interleukin 4 receptor antagonist, etc. We will not discuss that. So just to know what is controller, reliever and what is step therapy. Coming to the next question, previous year NEET question discussion 2025. Another question in respiratory medicine and it's a question on ABG. So, patient presents with chronic progressive dyspnea. He is a known case of COPD. ABG shows pH of 7.32, PCO2 of 60 mmHg, bicarbonate is 34 millimeters of mercury. In NEET 2025, 3 questions had come on ABG. So the normal pH is 7.35 to 7.45. pH less than 7.35 is called acidosis. And pH more than 7.45 is alkalosis. In this case, pH is 7.32, so this is an acidosis. Acidosis can occur due to 2 reasons. One, it is a respiratory acidosis or a metabolic acidosis. Any change with CO2, the prefix respiratory comes. Any change with bicarb, the prefix metabolic comes. So in respiratory acidosis, the carbon dioxide level has to increase. CO2 is basically an acid because it gets converted to carbonic acid. So when CO2 increases with acidosis, it's called respiratory acidosis. The normal PCO2 value is 35 to 45. So when the PCO2 increases more than 45 millimeters of mercury, we call it as respiratory acidosis. The normal bicarb is 22 to 26 milliequivalents per liter. When the bicarb is less than 22, we call it metabolic acidosis. So in this case, we have pH of 7.32, which is acidosis. So we have to see whether it is respiratory or metabolic. PCO2 is high, so it could be respiratory acidosis. Bicarb is not low, so it cannot be metabolic acidosis. So definitely this is a respiratory acidosis. Right? So ABG is low, so it's acidosis. PCO2 is high and it is respiratory acidosis. The question itself gives a clue. It's a chronic progressive case. The patient is having a chronic respiratory disease. So this obviously has to be a chronic respiratory acidosis. You need not break your head to put the calculation to know whether it is acute or chronic respiratory acidosis. The clinical clue itself says it is chronic respiratory acidosis. If at all you want to know the formula, in acute respiratory acidosis, there is something called as compensation. What is compensation is, when PCO2 increases by the same direction rule, the bicarbonate also has to increase to compensate for the rise in PCO2. In acute respiratory acidosis, for every 10 rise in PCO2, the bicarbonate should rise by only 1. There is no time for compensation. Whereas in chronic respiratory acidosis, for every 10 rise in PCO2, the bicarbonate should rise by 4. So our value is 60, which is around 20 millimeters above the normal range of PCO2. So when there is 20 rise in PCO2, in chronic respiratory acidosis, the expected bicarbonate should be above 8 of the expected value. That is 8 plus or minus 2. The normal average bicarb is 22 to 26. We will take 24 as the normal value. So 24 plus 8 will be 32 is the expected bicarbonate plus or minus 2. Our case it is 34. So the compensation formula also fits. So it is actually a compensated chronic respiratory acidosis. You need not, for this case, during the exam, you need not go to the compensation step at all, because we clearly know it's a chronic respiratory acidosis and it's a chronic case by the history. So you can straight away mark the answer of chronic respiratory acidosis. Okay. Coming to continuation of the previous year NEET question 2025. A question on nephrology. So we will read from the last line. What explains the adverse effect? Okay, it's a small question. A patient on hydrochlorothiazide develops renal stones. So the question may seem a little complicated. So we'll just take some time to read about two important diuretics. Loop diuretics. I chose this question for discussion because many onliners can come from this concept, not this question actually. Loop diuretics and thiazide diuretics. So if you think of the nephron, we have glomerulus, proximal convoluted tubule, and we have the loop of Henle, the descending limb, the loop, and the thick ascending limb of the loop of Henle. This is the thick ascending limb of loop of Henle. We have one important channel here, which is NKCC2 channel, that is sodium potassium 2-chloride channel. Okay. Loop diuretic inhibits this channel. Whereas in thiazide diuretic, we have the next step. Following the loop of Henle, we have the distal convoluted tubule, where we have NCC, that is sodium chloride cotransporter. Sodium chloride cotransporter. thiazide diuretic inhibits that. So when the reabsorption of these ions in the thick ascending limb or the distal convoluted tubule happens, the renal tubule gets concentrated with these ions and it gets excreted. Okay. One important difference between loop diuretic and thiazide diuretic is there is something called as solvent drag, which means even though only these ions are inhibited technically, by the ionic difference and by the charge difference, there's something which occurs called as solvent drag. Many other ions also get excreted. So in loop diuretics, what all ions get excreted is sodium gets excreted through the kidneys, chloride gets excreted, potassium gets excreted, calcium gets excreted, magnesium gets excreted. Okay, so these major ions get excreted. In thiazide diuretic is similar to loop diuretic. The only difference is calcium does not get excreted. So sodium, chloride, potassium and magnesium all get excreted, but calcium is not getting excreted. So when you tell like this, we can use another technical term. Since calcium is getting excreted, we can call that term as hypercalciuria. In loop diuretic, hypercalciuria occurs, whereas in thiazide diuretic, there will be hypocalciuria. Okay. Since more amount of potassium, more amount of these ions are getting excreted, what all can occur? Hyponatremia can occur. Hypokalemia can occur. Hypochloremia can occur. Hypomagnesemia can occur. That is low amount of these ions in blood. Since calcium is also getting excreted, that is, since there is hypercalciuria, patient will have low calcium in blood, that is hypocalcemia. Okay. So in thiazide loop diuretics, there will be hypocalcemia. So what happens in thiazide diuretic? Nearly the same. Sodium gets excreted, so it causes hyponatremia. Potassium gets excreted, so it causes hypokalemia. Chloride gets excreted, so hypochloremia. Magnesium gets excreted, so hypomagnesemia. But hypocalcemia will not occur because there is hypocalciuria. That is the only main difference between loop diuretic and thiazide diuretic. In loop diuretic, calcium is also getting excreted, so it is called as a powerful diuretic. Thiazide diuretic will not cause that much of hypomagnesemia. Another small technical difference, try to remember it if you can. Loop diuretic causes more of water excretion than sodium excretion, so the hyponatremia is less pronounced in loop diuretics. Whereas thiazide diuretic causes more sodium excretion than water excretion, so hyponatremia is more pronounced in thiazide diuretic. So if you compare loop diuretic and thiazide diuretic, loop diuretic causes less hyponatremia compared to thiazide diuretic. You can try to remember if you can. Now if you extend these points clinically, because of this point, because loop diuretic causes more of hypercalciuria, loop diuretic can cause calcium stone formation. Whereas since in thiazide diuretic hypocalciuria is there, it actually protects against calcium stone formation. So thiazide diuretics are one group of drugs which are used in chronic calcium stone formation to protect against calcium stone formation. Actually, this question is that only. Patient is on hydrochlorothiazide, which is a thiazide diuretic. He might have been given hydrochlorothiazide to prevent stone formation, to prevent calcium stone formation. Remember, there are 4 types of stones, right? A side note: calcium oxalate stones, citrate stones, uric acid stones, and we have the triple stones or struvite stones. Okay. So everyone has different characteristics. To prevent calcium stone formation, we actually give thiazide diuretic. One example for loop diuretic is our famous furosemide or toracimide. One example for thiazide diuretic is chlorthalidone or hydrochlorothiazide. Okay, so I think this will be clear. Loop diuretic acts on NKCC2 channel in the thick ascending limb of loop of Henle. Thiazide diuretic acts on distal convoluted tubule sodium chloride cotransporter. Sodium, chloride, potassium, calcium and magnesium all are lost due to loop diuretic, whereas calcium is preserved in thiazide diuretic. So there will be hypercalciuria with loop diuretic. There will be hypocalciuria with the thiazide diuretic. So hypocalcemia occurs with loop diuretic, whereas all the other remaining hyponatremia, hypokalemia, hypochloremia, hypomagnesemia occurs with both, but hypocalcemia occurs only with loop diuretic. Hyponatremia is less pronounced with loop diuretic, it is more pronounced with thiazide diuretic. So calcium stone formation is more with loop diuretic. Calcium stone formation is protected on using thiazide diuretic. Example of loop diuretic is furosemide and toracimide. Example for thiazide diuretic is hydrochlorothiazide, etc. Another one important extended value is, if you remember the mnemonic BFGT, boyfriend got time. B stands for Bartter syndrome. So Bartter syndrome is one channelopathy of the kidney which causes electrolyte imbalance. Bartter syndrome is similar to furosemide. GT, Gitelman syndrome, is similar to thiazide. So just remember the mnemonic: boyfriend got time. So if any question, even though questions may not be asked on furosemide or thiazide, questions may be asked on this. So if someone asks you the question, which of the following syndromes causes hypocalcemia, Bartter will be the better option, because Bartter and furosemide are the same. If you remember, furosemide is a loop diuretic which causes hypocalcemia. Bartter is an ionic channelopathy which causes the same. Gitelman syndrome, there will not be hypocalcemia. So in the evaluation of these syndromes, there is something called calcium chloride ratio in urine. Since calcium is lost due to Bartter syndrome or furosemide, the calcium chloride ratio is increased in urine in Bartter syndrome, whereas it is decreased in Gitelman syndrome. Okay, just remember, Bartter syndrome there will be hypocalcemia. Gitelman syndrome there will not be hypocalcemia. So to discuss this point only, I chose this question. So we'll read the options. So patient on hydrochlorothiazide, he develops renal stones. What could be the effect of this? He said due to increased urinary calcium. We just discussed now, thiazide does not cause increased calcium excretion. It causes hypocalciuria only. There is decreased urinary calcium excretion. So option A is wrong. So option B is actually the effect of thiazide diuretic. There is decreased urinary calcium, but is this the cause of adverse effect? No, because we just discussed hydrochlorothiazide is protective against renal stone formation, especially calcium oxalate stone formation, because of decreased urinary calcium. So even though decreased urinary calcium is an effect of hydrochlorothiazide, Don't be impulsive in writing this as the answer, because it is not the answer for this question. It does not lead to stone formation. Decreased urinary citrate. I think this could be right, because if you remember the pathogenesis of stone formation, citrate is a substance which prevents against stone formation. So decreased urinary citrate actually can lead to stone formation, but whether thiazide leads to decreased urinary citrate, we actually didn't discuss. Actually, this is one of the effects of thiazide. There will be decreased urinary citrate. Just remember it as an add-on. Increased urinary citrate is not the wrong answer. It's the wrong answer. Even if you don't remember other options, in this case you can easily exclude increased urinary calcium and decreased urinary calcium. And if you had read somewhere that urinary citrate is an anti-stone formation molecule, decreased urinary citrate can easily come as an answer to you, right? That is the reason why you should discuss multiple points in multiple subjects. In somewhere it may help you to get associated. Continuing with your previous year NEET question, 2025. So what is the most appropriate next step in management? So we are supposed to find out the diagnosis and what's the most appropriate next step. It's not the best step, they are asking only the next step. So keep that in mind. A 56 years old male patient with CKD presents with fatigue, dyspnea and exertion and signs of heart failure. On evaluation, he is found to have hemoglobin of 8.5. What is the most appropriate next step? So it's a case of CKD with anemia. What's the most appropriate next step? Oral iron therapy, IV iron therapy, blood transfusion, darbepoetin alpha. All of this actually is used in anemia of CKD. So we have to think a little bit. So we'll just decode what type of anemia this is. So for a male patient, HB less than 13 gram per cent is anemia, right? For a non-pregnant female, for a male patient, less than 13 grams is anemia. For a non-pregnant female, less than 12 gram per cent is anemia. For a pregnant female, less than 11 gram per cent is anemia. And we had heard about the terms mild, moderate and severe anemia. For ease of understanding, whatever be the category, less than 7 gram per cent is severe anemia. 7 to 10 gram per cent is moderate anemia. 10 to 13 or 10 to 12 is mild anemia. Why it is important is, when HB is less than 7 gram per cent, it's an indication for transfusion. In case of heart failure, in some books they may say 8 gram per cent is appropriate, but we'll keep 7 or 8 as the study. Even if we keep 8, this patient's HB is 8.5. It is moderate anemia. So blood transfusion is not needed. So that option will score it off. So the answer has to be either oral iron or IV iron or darbepoetin alpha. Darbepoetin is a type of erythropoietin. You would have read in your physiology the hormonal functions of tubules of kidneys. It produces erythropoietin. So in CKD or in tubular diseases, due to erythropoietin deficiency, there will be anemia. And one of the sites of vitamin D production, like one step comes in kidney, the 25 hydroxylation of vitamin D occurs in kidney, renal tubules. So deficiency or a CKD will lead to vitamin D deficiency. So these two things will occur in CKD. So anemia of CKD is actually due to erythropoietin. So erythropoietin may seem appropriate, but for this case, just remember one point. Blood transfusion is definitely not needed, but before giving erythropoietin, in CKD, always anemia has to be corrected. Iron deficiency has to be corrected. Iron deficiency has to be corrected before giving erythropoietin. In this case, we couldn't find out any evidence of iron, but what is the most appropriate next step? Whether we have to give iron or darbepoetin. Usually when HB comes more than 10, then only darbepoetin or erythropoietin is indicated. So up to 10, only iron is indicated. So will you give oral iron or IV iron? In CKD, a substance called hepcidin is high. Hepcidin is a molecule which negatively affects iron absorption. So when hepcidin is high, especially in CKD, oral iron absorption gets reduced. This also you would have discussed in your pathology discussion. When hepcidin increases, iron absorption decreases. We are not discussing the actual details. So whether will you give oral iron? No, IV iron is preferred. Now a recent drug has come, which is desidustat or roxadustat. If you are able to remember it, just remember, it may come as an update. Another factor causing anemia of CKD is HIF, hypoxia inducible factor. This gets negatively affected in CKD. Okay, hypoxia normally leads to increased erythropoietin and increased HB production. That is why in chronic smokers or patients with chronic hypoxia or in patients who are in high altitude, there is hypoxia. When there is hypoxia inducible factor gets activated. This increases erythropoietin production from the kidney and there will be increased HB or polycythemia. Hence the term smokers polycythemia or high altitude polycythemia. Okay. That is why in hypoxia or polycythemia cyanosis occurs. But this hypoxia inducible factor is negatively affected or its production is low in CKD. So if we are able to increase this hypoxia inducible factor, then we can treat anemia. So this desidustat or roxadustat is a hypoxia inducible factor stimulator. So it's a recent drug used in anemia. So if at all you want a summary slide on treating anemia in CKD, if it is severe anemia, blood. If it is moderate anemia, before erythropoietin, iron. So it is not oral iron, it is IV iron infusion. Or you can also use the HIF, hypoxia inducible factor stimulator, desidustat or roxadustat. And when HB is mild, like when iron deficiency is corrected, when HB is more than 10 gram per cent, then you have to give erythropoietin. In this case, actually, you need not analyze the first part. Actually, it's anemia of CKD. What's an appropriate next step? If you want added points, dyspnea next session. What are the causes of dyspnea in CKD? Obviously, one is anemia. We have pulmonary edema, which can occur due to CKD. Especially in renal artery stenosis, we can have flash pulmonary edema. Because these can all come as clinical case scenarios, that's why I am telling. Uremic pericarditis can also be a case scenario. So how will you get the case? Patient comes with chest pain. On auscultation, you may hear a pericardial knock. So that may be the clinical scenario given. And acidosis. high anion gap metabolic acidosis. This also causes breathing difficulty. Like on here examination, there will not be any finding. There will not be crackles of pulmonary edema. There will not be pericardial knock. There will not be pericardial effusion. There will be acidosis. So these can come as clinical case scenarios in CKD. So the answer in this case is IV ion therapy. Continuing with our previous year NEET question, 2025 PG NEET. This is a rheumatology question. So it's a big question. We'll read from the last line. Which diagnostic modality will pick up the disease process at the earliest? So the earliest investigation of choice, that is the question. A young male presents with chronic low back pain and morning stiffness and pain for 1 hour, which improves with activity. X-ray of the LS spine is normal. The patient also has anterior uveitis on clinical examination. Hope the diagnosis is more or less clear. It's a chronic low back pain. Whenever a question comes, this is a rheumatology question, whenever a case scenario comes on low back pain or joint pain, our approach is we have to differentiate between two types of pain. Whether it is an inflammatory pain or a non-inflammatory pain. Because non-inflammatory pain, the diagnosis will go towards ortho or a surgery question. If it is inflammatory pain, the answer will go towards a rheumatology. So the main clue for inflammatory pain is early morning stiffness more than 30 minutes. So early morning stiffness or pain more than 30 minutes. And pain which is more on rest and relieved with activity. Non-inflammatory will be the opposite, where there will be early morning stiffness or there will be early morning pain, but the early morning stiffness or pain will be less than 30 minutes. And the non-inflammatory, the pain will be relieved with rest and it is more with activity. So this is how you differentiate inflammatory pain from non-inflammatory pain. So the examples for inflammatory conditions, inflammatory back pain is actually rheumatology, right? So we can classify into axial diseases. Axial is anything from the spine, and appendicular diseases. The commonest appendicular cause of inflammatory pain is rheumatoid arthritis. So another question had come in last year's NEET. In rheumatoid arthritis, what is the pathology? There's something called synovitis or pannus formation in the synovium. Okay, so just an added point. So rheumatoid arthritis is the major inflammatory pain affecting the appendicular skeleton or the small joints or the limb joints. So we discussed one question. It causes synovitis or pannus formation. Other clinical clues will be it's a polyarthritis. It can be associated with other diseases like interstitial lung disease. Okay, it can cause pleural effusion. So these are some of the clues. And what is the test of choice? We have rheumatoid arthritis factor and we have another marker called as anti-CCP, anti-citrullinated C peptide, citrullinated C protein. These are some of the clues for rheumatoid arthritis. In rheumatoid arthritis, RA factor or anti-CCP will be positive. There can be some diseases where again appendicular skeleton like the hand joints or knee joint or shoulder joint or wrist joint may be affected, but this RA factor or CCP is negative. So they are collectively called as seronegative arthritis. So if a clinical question comes like RA factor is negative or anti-CCP is negative, your mind should directly go towards seronegative arthritis. So there are actually 4 seronegative arthritis. One is axial and one is 3 are appendicular. They are psoriatic arthritis, IBD arthritis, reactive arthritis. Psoriatic arthritis, patient has a clinical question on psoriatic arthritis. Some clinical questions may come like rheumatoid arthritis affects the proximal interphalangeal joints. Psoriatic arthritis affects the distal interphalangeal joints. So this can come as a clue. IBD arthritis, patient will have ulcerative colitis or Crohn's in the background. They will have a bloody diarrhea as the clinical question. Reactive arthritis, patient will be usually normal. They would have had a fever or UTI in the past. Our famous Ritter syndrome, the triad of polyarthritis, conjunctivitis and UTI is also a reactive arthritis. So psoriatic arthritis, IBD arthritis and reactive arthritis are appendicular variants of seronegative arthritis. But we have the main seronegative arthritis which affects the axial skeleton or the spinal joints, which is AS, ankylosing spondylitis. So there are 4 seronegative arthritis. One is ankylosing spondylitis, which affects the spine. Psoriatic arthritis, IBD arthritis, reactive arthritis affects the appendicular skeleton. Among all rheumatological diseases, usually autoimmune diseases or rheumatological diseases are common in females, except seronegative arthritis, which are common in males, young males. So it presents with low back pain. What type of low back pain? Inflammatory low back pain, right? Inflammatory type of low back pain, which means it is more on rest, early morning stiffness more than 30 minutes, and it is relieved with activity. The earliest joint affected is SI joint, sacroiliac joint. So sacroiliac joint arthritis is the earliest imaging marker, and it is early picked up in MRI. In the later stages, like when it crosses more than 10 years, only then we can pick up the classical X-ray finding, which is bamboo spine. So this has become outdated because it takes 10 years for ankylosing spondylitis to produce bamboo spine, but we can pick up earliest in MRI. That is actually this question. See, patient is having a chronic low back pain. He is a male. There is morning stiffness and pain for 1 hour. So it could be an inflammatory arthritis, which improves with activity. Again, it is a finding of inflammatory arthritis. And it is the appendicular skeleton. It's a back pain. Spine is affected. And X-ray of the LS spine is normal. So I already told you it will take 10 years for X-ray spine to produce bamboo spine. It's a late pickup investigation. And will serology help? No, because it's a seronegative arthritis. If at all something can be done, HLA-B27 is a genetic test which may help, may not help. Maybe for your MCQ, HLA-B27 you just remember. And the associated features of ankylosing spondylitis will be anterior uveitis. In ophthalmology, please read anterior uveitis. Please see images on anterior uveitis, because so many systemic diseases are associated with anterior uveitis, like tuberculosis, ankylosing spondylitis. Then we have Behçet's disease. Behçet's disease is called oculo-orogenital syndrome. So it causes ulcers everywhere. It causes genital ulcers, oral ulcers, ocular ulcers and anterior uveitis. Behçet's disease, the gene associated is HLA-B51. So 2 genes we discussed now. HLA-B51 is for Behçet's disease HLA-B27 is for ankylosing spondylitis. I think this will summarize most of the important questions in rheumatology and back pain. So we'll discuss the options now. So anterior-uveitis, early morning stiffness, back pain. This mostly comes to ankylosing spondylitis. Which modality will pick up earliest? MRI. So will anti-CCP help? No, because anti-CCP is the investigation of choice for rheumatoid arthritis. This is actually seronegative arthritis, so anti-CCP will be negative. MRI of sacroiliac joint is the answer. CT of sacroiliac joints, no, better investigation is MRI. Bone scan will pick up only bone metastasis, and it is used to diagnose osteoporosis. Osteoporosis is actually picked up by DEXA scan, dual energy X-ray absorptimetry. Okay. So continuing our previous year NEET PG question series of 2025. This is the final question. I have compiled 2 or 3 questions into one question. I would have discussed 2 or 3 questions in one discussion itself. So with this we'll finish our 2025, and from the next video onwards we'll continue with 2024 questions. Okay, so it's a small question, we'll read from the front. A patient came with fever, headache and neck rigidity. Lumbar puncture shows gram-negative diplococci in gram stain. Which of the following will be used in chemoprophylaxis of close contacts of a patient with meningococcal meningitis? You need not break your head with the first part because the second question is straightforward. What is the drug used for chemoprophylaxis of patients with close contact with meningococcal meningitis? So meningococcal meningitis, what is gram-negative diplococci? Cocci is round bacteria. Diplococci is two coccus together. We have 2 gram-negative diplococci. One is Neisseria gonorrhea, which causes gonorrheal venereal disease, and another one is Neisseria meningitidis. So Neisseria gonorrhea is shortly called gonococcus. Neisseria meningitidis is called meningococcus. Meningococcus is one important cause of meningitis. It is an important cause of meningitis for your questions because it can be picked up from clinical clues. So I'll tell the few words associated with meningococci. So one is gram-negative diplococci. Gram-negative cocci diagnosed in gram stain of the CSF. That is how you diagnose. In microbiology, you would have discussed specific culture medium like chocolate agar. Okay. Then it is one dangerous disease which causes adrenal insufficiency or Waterhouse-Friderichsen syndrome. It is one meningitis which causes skin rashes. So like they can give a clinical clue. Patient comes with neck stiffness, altered sensorium, there is extensive skin rash. Patient has hypotension. Remember adrenal insufficiency, Waterhouse-Friderichsen syndrome. So when such clinical clues are there, we can easily diagnose it as meningococcus. So how will you treat? How will you prevent? Treatment is ceftriaxone. Ceftriaxone 2 grams. It is high dose ceftriaxone. Other drugs also can be used like ampicillin, etc. can be used, but remember one drug which is ceftriaxone. How will you prevent? Because we have to prevent a particular person from getting it, and we have to prevent contacts from getting it because it is a highly contagious disease. Prevention is always by vaccine. We have meningococcal vaccine. If time permits, in the last minute you can just read about the vaccine strains. We have meningococcal vaccine. This is a favorite question. How will you prevent contacts? It's by rifampicin. Of course, ciprofloxacin also is a drug which can be used, but rifampicin. Ciprofloxacin is a antibiotic with predominant coverage of gram-negative organisms. That's why it can cover meningococcus. But ciprofloxacin cannot be given in children because it causes cartilage toxicity. Similarly, it cannot be given in pregnancy. So rifampicin is preferred. In this question, I think there is no confusion because rifampicin is the only option which is there. Amoxicillin is not used in meningitis at all. Doxycycline has a role in meningitis, but it doesn't have a role in meningococcal meningitis. Ethambutol is a drug for tuberculosis. So rifampicin is obviously there. So treating meningococcal meningitis is ceftriaxone. Preventing meningococcal meningitis is rifampicin, ciprofloxacin. If at all these two drugs cannot be used, we can rarely use ceftriaxone IM in few cases, like single dose ceftriaxone. Okay, rifampicin, ciprofloxacin, and ceftriaxone. Since we started meningitis, what are the other questions which can come from this topic? Since video-based questions are common, we can get videos on Brudzinski sign, or there can be video of a person examining neck stiffness. Okay, like those videos can be given and questions on meningitis can be framed. So please do see some videos on neck stiffness. And in our previous question, like on ankylosing spondylitis, we may get some videos on Schober's sign. Like Schober's test is one clinical test. Schober's test is a test where we ask the patient to bend and we measure the distance from the posterior superior iliac spine, just for a measurement's sake. So like videos examining the Schober's test may be given and they may ask question which disease is diagnosed by this test. It is ankylosing spondylitis. If time permits, you just see videos on this. And one more place where questions on meningitis can come is, they may give you a report of lumbar puncture and they may ask you what organism may be there. If a lumbar puncture is given, our aim is to differentiate whether it is a bacterial meningitis, viral meningoencephalitis, or if it is a fungal or tubercular. I think we'll keep tubercular, then fungal. Remember, in always bacteria, neutrophil will be excess. Cells will be high, but neutrophilic predominance is the important finding. Virus and TB, always lymphocytes are high. Virus and TB, always lymphocytes are high. Fungus, again, it's like bacteria, so there will be neutrophils. So I think we can write it in a different color. Fungus and bacteria will have neutrophils. Viral and tubercular will have lymphocytes. Then how will you differentiate viral and tubercular? We have the glucose. When cells are very high, or when organisms, live organisms are there, it will consume more of glucose. So tuberculous bacteria are live organisms, so glucose will be low in TB, whereas glucose will be normal in viral. So there is a lymphocyte predominant CSF with low glucose. With low glucose, it is tubercular. With normal glucose, it is viral. Usually they will be giving the reference range. What is the normal CSF glucose? If it is not given, remember, blood glucose level, patient's blood glucose level divided by 2 is the normal glucose of CSF. If the patient's blood glucose is 180 milligram per deciliter at the time of doing lumbar puncture, at that time the CSF has to be 90. 50 to 60%, 90 to 100, maybe you can keep as the range. If it is less than 50%, then it is low CSF glucose. Again, bacterial also, glucose will be low. Fungus also, it will be low. Then proteins. Proteins will be very high in bacterial, whereas it will be low in viral Again, since TB bacteriaceae, it will be high in tubercular, it will be moderately high in fungus. And they may give a few specific clues on organisms, like we have discussed just now in bacterial, in meningococcus, there will be gram-negative cocci which can be seen in gram stain. In tubercular, they may give the word cobweb formation. In few fungus, they may give the clue of cryptococcus. Cryptococcus is a fungus, remember. They'll give the word India ink stain. So maybe these clues can help you. So bacteria is neutrophilic, fungus is neutrophilic. Viral and tubercular are lymphocytic. Glucose is normal with viral, it is low with bacterial and tubercular. Proteins are high with bacteria and tubercular, it is low with viral. And based on the specific clues, maybe you can pick. Sometimes, if it is viral meningoencephalitis, they may give MRA as the clue. The temporal lobe is commonly involved in herpes simplex meningoencephalitis. That is why herpes simplex meningoencephalitis will cause behavioral disturbances because temporal lobe is involved. Another virus, Japanese encephalitis, this affects the basal ganglia. At least remember these two. Okay. So we just started with discussing one question. We have discussed the associated questions as a rapid revision. So this finishes our 2025 NEET PG question, previous year question discussion. From next video, we will discuss 2024 previous year NEET PG questions.